Hello, welcome to ATP Life, the First Antenatal Clinic in ATP, still in Mom, Nigeria. So I'm waiting for Dr. Jumoke to join me soon. So please share the video, and if you're watching, let me know you're watching. You can drop a comment, and I'll be able to see who is watching. If you want your name to show, you need to click to allow StreamYard to allow your name to show. So welcome to um, our first ANC clinic with Dr. Jumoke Ogunro. So she'll be joining us soon. I'm waiting for her to join me. Yeah. So just waiting. So meanwhile, let's just share the video and let's make sure everybody can see this. Today we're discussing miscarriages and newborn deaths. So just waiting a minute for Dr. Jumoke. Okay, I think Dr. Jumoke is here now. Hi, Dr. Jumoke. Can you hear me? Can see you. All right. Dr. Jumoke, you're connected, but we can't see your video and audio. Okay, okay, good. I think you can see your video now, but your mic is muted. Good. Hi, Dr. Jumoke.
Hi. Hi. Sorry,
Your
I'm
face
just trying
is
to.
blurry. Can you face your light? I'll go live on Instagram now.
Okay, can I face the lights?
Yes, that
Okay,
way
just
it will make your face clearer.
shut
Yeah,
it.
lovely. Yeah. Hi everyone.
Okay,
Okay. So yes,
yeah.
welcome Dr. Jumoke.
Hi.
It's my pleasure to have you with us. Yeah, this is lots
Thank
better.
you.
So welcome everyone. This is our first ATP Still a Mom Antenatal Clinic on the live antenatal clinic. So you're welcome whether you're watching on Instagram, on YouTube, or on the Still a Mom Facebook group. You're all welcome because I think it's something that applies to all mom. The ATP Still a Mom group is just a week old. Not even a week old. It's actually five days old. Okay, so this is a group I just created because
5 days.
yeah,
Wow.
it was created last Sunday. I created this group because as a pediatrician, I get a lot of mom coming to my inbox and who have lost their babies, either their pregnancies or the babies after shortly after delivery or during labor, and they are really so distressed, and they need support. So I try to do the little support I can, and most time I usually refer them to a friend of mine, who I met in Facebook Community Leadership Program. That is why Njiru. She runs a beautiful group in Kenya for such moms who have lost their babies either during pregnancy or during delivery or shortly after, trying to provide them some psychological support and all that. And so this, but I realized I'm doing a lot of referrals to her. So we decided that, okay, let's create a similar group for the Nigerian mothers. Parents generally anyway, but usually we know mothers are the ones that tend to reach out for support when it comes to child death, and that is why we created the group. So the goal is to provide support for moms, and so I created a poll on that group, and the poll was, what kind of support do parents want, the moms in the group wants, and the number one support most of them want is that they actually want to speak to a gynecologist. They want to know what happened. They want to know what they can do to avoid the recurrence. And some of them felt that, during those grief, the having another pregnancy and having another baby is one way they tend to. I found out that mothers who have not had a new baby tends to kind of, even though they are still grieving, but they tend to come out better than those who have gone through it and they are still, waiting for another baby. So that is why, okay, we decided that we will be bringing a specialist, gynecologist, to talk to mom to help them understand what happened and to see how they can avoid. So that number one support most mothers want is that they want a gynae clinic. They want to talk to the professionals. They want to understand what really happened. Of course, they also want one-to-one support group and all that. So just to give a background on why we are having this clinic today, so the goal is to see how we can support mothers and who have been bereaved, whether through loss of a pregnancy or a newborn baby, to see. And most of them wants to know, why did they miscarry, why did they lose the pregnancy, and why, and what can they do to avoid it happening again. So I'm so excited to have with me today an award-winning gynecologist and author, Dr. Jumoke Ogunro. She's a gynecologist of close to 2 decades, and she has also written a book called 9 months and beyond. It's about pregnancy, everything you need to know about pregnancy. So that's more like your antenatal guidebook, and even beyond antenatal, during the labor, during the delivery, and beyond. So I was able to contribute a chapter on neonatal care there as well. So this is it's my pleasure to welcome Dr. Jumoke here. So Dr. Jumoke, you are welcome to
Thank
our
you.
Antenatal
Thank
Clinic
you.
first edition. All right. So I'm live
Thank
on
you.
Facebook.
Thank you
I'm
so
live on
much for
Instagram.
inviting me.
Yeah, you're welcome. And so if you have questions, please drop your question in comments. What I'm going to do is to quickly let Dr. Jumoke just talk to us first, and then to tell us why do we have there are different terminologies: abortion, miscarriages, fetal death. I think Dr. Jamake will tell us those definitions. Basically, why do we have pregnancy losses and child newborn deaths? Maybe I can also chip in a little bit in that area after Dr. Jamake has talked about their own aspect, and then we look at what can we do, what can mothers do so that this doesn't happen. Is number one, is it even possible to prevent it? Is it not possible? Or if it is possible to prevent, then how do we do that? So I will let Dr. Jumoke talk to, but so we will keep that aspect short. So, but once we have done this background, please drop your question. I know most of you have questions, and I've told you, come your questions, whether you're whichever platform you're watching from, drop your questions early so that Dr. Jumoke will have enough time to answer them. All right. So, Dr. Jumoke, do you want to tell us, do you want to define to us what is abortion, what is miscarriage, what is stillbirth, what is newborn death? Do you want to quickly run through that?
All right. So thank you again, Dr. Boyede, for having me. Thank you for this group because it's an important group. Usually, women that have gone through miscarriages are usually neglected. In the ever busy antenatal clinic or gynae clinic, even the physician does not have time to really empathize with the woman. So many patients to be seen, you understand, and it's very easy for us as physicians to come and say, mother, don't worry, you can get pregnant, and just reassure. And it's amazing because I'll tell you my own story. When I was in training, when you see women with that have had miscarriages, you tell them, madam, don't worry, you can get pregnant. Nature just has a way of eliminating something that is not viable. You understand? And you say, don't worry, you get pregnant. Until I suffered a miscarriage myself, then I knew that it was actually deeper than that. You understand? So
Mm,
I all my counseling came back to me, and my counseling
mm,
did not help me to, understand. So I know what a, a woman that has had a miscarriage goes through. Even after she even gets pregnant, you're talking about that there's always that fear. There's always that fear that, oh, what will happen, and you're always very happy when you pass the anniversary of that miscarriage. That is when you now get confident. And the more miscarriages the woman has, the more traumatic it is, the more less exciting the news of being pregnant becomes. All right. So thank you so much because these women actually need support, and the support is the older the child is, the more traumatic it is. So if the child is 6 weeks, well, it's traumatic but less. But as the child gets to 1 year, a loss at term is extremely traumatic because all of a sudden there is nothing to show. They've done baby room, they've done shopping, they've done a lot of things, and all of a sudden they enter the house and there are so many things reminding them that they were about to welcome a baby and the baby died. So usually the older the baby, the more traumatic it is. So what I want people to take home is that when a woman suffers miscarriage, she should be allowed to grieve. Because sometimes people just think 6 weeks, 9 weeks, what's the big deal? You understand, there's no big deal about it. But it is a loss.
mm,
Remember that 6 week fetus, that 10 week fetus is that is the one that, if allowed to live, or if everything was right, that fetus will
mm,
become a baby that will be palpable, will become a child later on. So it is a death. And when people suffer losses, people must be allowed to grieve. And so you shouldn't push
okay.
it away to say there's no big deal. After all, thank God it wasn't a child that you saw. Thank God it is still a loss. So let's quickly go
Mm,
back to what the definitions, that the question Dr. Boyede asked me. So when we talk about miscarriage, it's just the loss of a fetus before the age of viability. That's big grammar. When the baby dies before you can actually intervene. Viability means that, when the child is able to um, survive outside the womb. Let me put it that way. So, with the loss of a baby before the age of viability is what we call a miscarriage. That means viability is at that time, after that period, when it's a viable pregnancy, the baby is able to survive outside the womb. So the term, the age of viability differs from country to country. Unfortunately, in Nigeria, we're still stuck with 28 weeks, unfortunately. Where places like the US, they're talking about 20 weeks. So a baby that is above 20 weeks will not be considered as an abortus. Still in Nigeria, a baby that is 24, 25 weeks is still considered as an abortus, unfortunately. That's because we still don't have the wherewithal, all the equipment, gadgets to ensure that survival is possible. I think in the UK it's 22 to 24 weeks. Dr. Boyede, am I right?
yes.
The age of viability at your end, 22 to 24, so it's still 22 to 24
Yes.
weeks. But unfortunately, in Nigeria, it has always been 28 weeks since I was in medical school, and it's still 28 weeks, 21 years later, sadly so. So,
Mm,
usually, interchangeably, in the old terminology, or the old name was abortion. Abortion was for everything, you understand, whether it is a voluntary one, the one you intentionally aborted, or the one that the loss that happened on its own. But again, because abortion has this unhealthy, people always look at abortion as the intentional one. So that is why miscarriage is more common at this time. You understand? The abortion is almost like, oh, you did something bad. That girl went to commit abortion and everything. So it's basically the same. The abortion is the old terminology. Now, when the death happens after the age of viability, then we call it a stillbirth. All right. After 28 weeks, if a baby now dies after 28 weeks gestation in Nigeria, you call it a stillbirth, because at that time you can actually bring the baby out. The baby is nearer. And by the time the baby is born and the baby dies, you now call it an early neonatal death. And I believe in pediatrics, after seven days, you now say it stops being an early neonatal death. I believe it becomes a late one. So there are different reasons why people have miscarriages. But the truth of the matter is that miscarriages are very common, but they tend to occur. People even put it that 50% of all pregnancies actually end up in miscarriages. That means we call them
Wow.
subclinical pregnancies. That before a woman ever knows she's pregnant, she can actually suffer a miscarriage, but she has not missed her period, so she will not know. So if you count ever missed her period, the incidence can be as high as 50%. However, when we count clinical pregnancies, meaning pregnancies the woman has missed her period, she has already missed her period, she has already missed her period, 75%. All right. And the commonest cause a miscarriage is usually as a result of chromosomal abnormalities or genetic problems with the genetic makeup of the baby. So that was what I said earlier, that nature has. All right. So the commonest cause we know is when a baby is not had a problem with the genes. All right. There is a problem with the genetic makeup of the baby. So nature just has a way, rather than the baby becoming a liability or a nuisance to the parents, the baby, nature just has a way of clearing the baby. But there are other causes of miscarriages. Infections can cause miscarriages, okay? Even things as common as malaria, all right? Very, very severe malaria can lead to miscarriage. Viral infections, all right? Like the famous touches infections, people having rubella, because again, some of these infections actually cause congenital abnormalities, and nature just has a way of getting rid of anything that is not viable. Also, medical conditions. The mother having medical conditions also can predispose her to having miscarriages. Medical conditions like diabetes, especially when it is poorly controlled. When the woman has a poor control, it can cause a miscarriage. Also, problems with the thyroid disorders, even when the thyroid is under functioning, hypothyroidism has also been linked to miscarriages. All right. Then other causes of miscarriages include problems, abnormalities with the womb. Abnormalities with the womb. Some people they are born with some defects or abnormally developed womb, such that they may have only one, the womb is not well developed, all right, and it has a funny shape. So some are not compatible with people having a live birth. So the implantation may take place, but over time, the woman also has miscarriages. And recently, people have talked about immunological factors. Sometimes some people have the way the body responds, the woman's body response is to be able to accommodate that part of the paternal contribution to the fetus. But for some women, this mechanism is not put in place, and you find out that the woman has a lot of antibodies, natural killer cells attacking the fetus. So that is also a known cause of miscarriage. Also, sometimes some people have abnormalities with the neck of the womb. All right, they have weakness. The neck of the womb is called the cervix. And so when you have the weakness of that cervix, they may have miscarriages. But usually these miscarriages occur in the second trimester. We call it cervical incompetence or cervical weakness, or some people call it cervical insufficiency. And usually the classical symptom is that the woman just feels something pushing down, all right, as the pregnancy advances. Usually happens in the second trimester, when the weight of the baby is getting very heavy, and then she may break her water without even having any pain. She just breaks the water and expels. So that is the classical way that a woman with cervical incompetence may present. Also, so we've run through some of the causes of the miscarriages that people may have. But the good news is that 80% of women, most women that have had one miscarriage, will still go in the next pregnancy to subsequently have a normal pregnancy and deliver. However, the higher the number of miscarriages you have, the greater the risk. So people with two miscarriages have a 30% risk of having miscarriages. By the time they have three miscarriages, the probability of having a miscarriage in the subsequent pregnancy is about 43%. So the higher the number of miscarriages, the greater the probability that you may have a miscarriage in the next pregnancy. You said something about miscarriages, that can it be prevented? Well, we know that generally speaking, that there are certain risks to miscarriages. Older women tend to have a higher incidence of miscarriages, because we know that with older women, we know the quality of their eggs. They have a higher proportion of abnormal eggs. How would I say? They have a higher a proportion of eggs that are abnormal. And of course, we know that before you get the baby is the combination of both the sperm and the eggs. So if there's a problem with the chromosomal or genetic makeup of the eggs, then that would also result in a miscarriage. So older women tend to have a higher incidence of miscarriages. Also, people that have extremes of body weight, whether underweight or overweight, obese patients, also tend to be at risk. Also, people that smoke are at risk of having miscarriages, and likewise, people that use recreational drugs like marijuana, like hemp, and also excessive alcohol consumption, also at risk of having miscarriages. So when you say, can it be prevented? Well, maybe. So if, so, for instance, you've experienced miscarriages, you smoke, you drink, or you take recreational drugs, lifestyle modification can help you. Or if you find out that, oh, you're on the obese side, just trying to even lose weight, especially people with polycystic ovarian syndrome, when they are obese, they people with polycystic ovarian syndrome that are overweight or obese, there is a higher incidence of miscarriages. And it's also known that when they tend to lose weight, it also helps them to achieve that life birth that they desire. So when you say, can it be prevented? Yes, maybe. You can't really do much when it has to do with congenital abnormalities. And those are the times that sometimes after two miscarriages, when most people, when they have the miscarriage, they just want to move on. But if, for instance, this is like the second or the third miscarriage, it is always wise for us to take the tissue and test the tissue to find out, is it as a result of chromosomal abnormality? Is it as a result of the combination of the man and the woman? When we talk about HLA compatibility, that's big medical term, but sometimes just the combination of that couple, their egg sperm coming together, results in chromosomally abnormal children. And so sometimes you may have to do pre-implantation genetic screening, just to make sure that you want to try and find out what is going on. So when people have had miscarriages and the doctor is offering you that, madam, let's take the sample of the fetus, you're right, and check for chromosomal abnormalities, I think it's good, so that number one, it gives you closure, and then sometimes it may be able to answer some burning questions in your mind. But usually sometimes the couples, yes, they are traumatized and distraught, we understand. But also sometimes they also want to run away from the financial implication, because such tests are still a bit expensive in this environment. So when you are telling them to come and spend 100 and something, or 200 and something, or 300 and something extra after suffering a loss, most people will just say no. just say they are not, but it will also help you to find closure, to say, there's nothing wrong with me. It was just that the baby had congenital abnormalities, and it was just good that the baby just didn't continue to grow. So I don't
All
know.
right.
Let me stop there now and
All right.
see whether we
Thank,
have questions.
thank you, Dr. Jumoke. I think you have really done quite justice to the miscarriage questions. In other words, sometimes sometimes some miscarriages we can't prevent it. It's something nature happened, and the nature felt that this baby chromosomal combination may not be able to survive, so the nature kind of allow it to go. Okay, but you also mentioned some of the ones that the risk factors that we can avoid. But I think another question I want you to now address is, what about the mothers that already carry their babies to term, and then they still lost, they went to the hospital at time hoping to come home with a baby, and they still come back empty, and then what really went wrong at that point when we already think the baby, you already mentioned the one of the cervical incompetence which tends to occur midway during pregnancy. So what about the ones that, I mean, what normally happens? Why do some of us go into labor or even have the baby and then so what happened at that late stage that will still make a woman to lose her baby? Or some of them will now go for scan and they will discover that the baby is no longer kicking or baby's heart has gone. What happened at that late stage? You want to tell us, and whether there's something we can do about that as well? Thank you.
All right. So, all right. So that can happen. I mean, how will I say? We know that the womb is how will I say, the house. When the house has an issue, it tends to affect the
The
content. I
tenants.
mean, if you put something in a container, a bad
Mm,
container, for instance, and the tenants, yes, if you have a bad house and you have the tenants living there, okay, if the house crumbles, it's going to affect the tenants. So, and
yeah.
that is why we have antenatal care.
Mm,
The truth of the matter is 80% of women who deliver normally, they will be fine. They don't need antenatal care. That's the truth. But you have just 20%, a small fraction, that need attention. But the truth is,
mm,
who needs attention? Nobody knows. Problems can develop anytime. Hence, the importance of antenatal care. Not assuming that, oh, some people will say their birth, this is my third pregnancy, this is fourth pregnancy, everything is always smooth. Not knowing that as you get older, some medical conditions start rearing its head. All right. So we know that trimester hypertension can happen, usually after 20 weeks. Likewise, gestational diabetes, it can happen. With good antenatal care and having specialist care, your specialist can even run into problem. For instance, people with polycystic ovarian syndrome are predisposed to having things like gestational diabetes in pregnancy. Even your booking weight rings an alarm. If a woman, for instance, starts antenatal care, she's about 9 weeks or 10 weeks, she weighs 110. That tells me something, that this woman, I need to do glucose screening, a glucose challenge test, screen for diabetes, because she's at risk of having diabetes mellitus in
mm,
pregnancy. A woman, for instance, that comes to tell me that, oh, my babies are usually big, oh, doctor, 4.5. In fact, I've done 4.2. I should screen that woman for gestational diabetes in
mm,
subsequent pregnancies, because she is at risk. And we know that the gestational diabetes usually occurs later on. When a woman is about between that 24 weeks, 28 weeks, that's when it starts. And when the sugar is not well controlled, the pediatricians, they know, even when the baby is born, the baby is at risk of hypoglycemia, the baby will have jaundice, but the baby will be very, very big. Sometimes you may have shoulder dystocia. That's bringing the baby out may be very, very challenging. And then baby is compromised, may not be able to breathe well when the second stage of labor is prolonged. So all these things can compromise the baby, and if not well managed, can lead to death of the baby. We know in itself that diabetes in pregnancy is one major cause of stillbirth. If a woman comes and tells you that, oh, I had stillbirth at so weeks, at 30 something weeks, baby just died, at another week, you screen for diabetes. So medical conditions, very, very, very important. Okay, and that's those ones can happen. Now, a woman is in labor. You know, labor, normal labor, I would say, is a retrospective diagnosis. Until a woman delivers and everything is okay, you can say normal labor. She may start out well, and along the line, anything can happen. Okay, for instance, if her water breaks, her water might just break all of a sudden. All right, and then there is a sudden gush. That sudden gush sometimes can predispose to separation of the placenta. Remember, there is a placenta that joins the mother to the baby, and once the placenta has separated prematurely, then the mother cannot supply nutrients, blood, oxygen to the baby, and then that can cause death. So labor started well, but somehow something happened. Okay, sometimes when a woman breaks her water, whether it happens spontaneously or whether in the course of labor, an artificial rupture of membrane is done, you need to monitor. In fact, once you break the water, the next thing after breaking the water, as you break the water, you are looking round. Is the cord out? What we call cord prolapse. Is the cord out? Because once the cord comes out, it's not inside. There is compression, there is compromise, because it's the cord joining the placenta and the baby. So when that happens, can just cause sudden death. So there are so many things that can happen, and that is why for women it is so important that you do your antenatal care in a very good place, and also deliver in a very good place. That complications can happen at any time, even in the best centers and in the best hands. But when it does happen in very good hands and good centers, number one, they are identified and they are rectified immediately. So those are the things. And complications can happen at any time,
Yeah.
anytime, anytime. But then when you have a place where they are prepared, then that makes the difference. But sometimes, some people will say, oh, third pregnancy, fourth pregnancy, I don't need there's no problem. Let me just go to this place and let a nurse take it. Yes, you may think that, oh, all my pregnancies have been okay. What if something now happens? Sometimes, yes, when the cord is tightly when the cord is round the neck and it's quite tight, that can reduce and compromise. But when the woman is not monitored in labor, she won't know. And before you know, the truth of the matter is that the baby's heartbeat does not disappear like that. It gives warning sign. But when you are being closely monitored, the midwife or the doctor recognizes that, oh, this heartbeat is getting very, very fast, I need to alarm the doctor, or we need to do something. Or this heartbeat is getting very, very slow, we need to act fast. But when there is no monitoring, people just think everything is okay. Before you know it, the baby is gone. So a lot of factors, both man-made, medical conditions, anything can happen at all. We also have what we call resource factor. All right. For instance, a woman is resource negative, her husband is resource positive. In her first pregnancy, her baby was resource positive. Then usually, no matter the gestational age, even if it ended in a miscarriage, there is always a mixture of maternal blood and the fetal blood. So what happens is that the fetal blood goes to the mother and is sensitized. She develops antibodies. So in subsequent pregnancies, when you don't check or you go to a place where traditional birth attendants or whatever, they may not be aware of such things, such that if the next baby is also positive, then the woman now starts attacking the baby, and the baby develops hydrops, fetalis, and everything, and things happen. Even basic things of having your fetal anomaly scan can save the day. In very good centers, we've had the story of the Nigerian, I think that was last year or 2 years ago, that separated corrected the congenital abnormality and then returned the baby back into the womb. So, things can happen. It is that complications can happen is not anything new. But then there are things that can be put in place to prevent these things. And this thing can happen when you go to very good centers for antenatal care and delivery.
Thank you, Dr. Jumoke, because please, thank you so much. For those who are watching, whether on Instagram, for those on Instagram, I've already turned my laptop towards you so that you can see Dr. Jumoke, because I don't want you to be seeing only me. So I guess that is better. And for those on Facebook and YouTube, you can see us. Please, if you have questions, please drop your questions. We will start taking the questions now. But before we start taking questions, I just want to run through, because I can see some of you want to know about the newborn. Because obviously, Dr. Jumoke and her team, sometimes they have done their own part and they've delivered the pregnancy successfully, and your baby is there. And sometimes things still happen. And one of the things Dr. Jumoke said, which I want to hammer on, the difference between us and some of these other countries where women dying from from pregnancy, or from babies even being dead, either from pregnancy or during the delivery or all that. It's about the care. It's about care. And she kept hammering on going to a good center, a center. Some of us are too confident. I know some of us that go to churches to deliver. I know some of us that deliver at home. Some of us that deliver in what we call Alagbo or TBA. The problem is that those people that don't have any problem, like Dr. Jumoke said, 80% of you will not have problems. 80% of you will have your baby, whether you deliver at home, at Alagbo, or at church. But what about those 20% that may run into trouble? So those are the 20% that we are really hammering on. And unfortunately, there's no way to know those 20%. I hope Dr. Jumoke comes back. So there's no way to know those 20%. And because there's no way to know those 20%, that is why it is important for us to have this conversation. It is important for us to know. So having a baby, there must be somebody at that delivery that knows how to resuscitate a baby, because if there's nobody at that delivery that can resuscitate your baby, things can go wrong. All midwives, all doctors must know what we call newborn resuscitation, because the baby being born is not enough. The baby must cry. The baby must cry, and that baby has to cry within the first 5 minutes. And so what the pediatrician does, sometimes the babies are born, they are not crying at all. We know what to do. The first 1 minute, we call it the golden minute. You must make sure that baby starts to breathe. So we have our way. We suction the mouth. Sometimes we give oxygen. Sometimes we have to press the heart. We have to do those resuscitation. So that is why it's important that you deliver in a good center where the baby can have this opportunity. And then also the baby needs to be fed, because sometimes within 1 hour babies must be fed. Some babies are born and all this one we're giving them glucose or ordinary water is not the right thing. Baby must be fed either breast milk. And if for any reason there's no breast milk, baby must be fed formula, within that first 1 hour. Some hospital, they should check the glucose level of the baby to know whether the baby has what we call hypoglycemia. It can kill the baby as well. It may also not kill them, but it can cause brain damage. So these are the care the baby needs to receive shortly after delivery. The baby must be monitored. So before you start announcing welcome baby, we must make sure that the baby also gets properly monitored. A doctor must examine every baby. It doesn't have to be a pediatrician, but a doctor must examine the baby, count the finger, count the toes, check the heart. Some babies have what we call some congenital anomalies that they may not have picked up by scan. Because they didn't pick it up, they will. Some of them, if we know on time, we can do something about it. Some of them, you will not give baby oxygen because the hole that connects the hearts may close, and that will cause a problem for the baby. So this is why sometimes some people will have babies, and within 1 or 2 days, baby has gone back. So the reason why that happens is because nobody is checking the baby, nobody is monitoring the baby, nobody is making sure that the baby is fine. So it is important that we all make sure that we do all the baby is also checked. So it's not just the mother that needs to be monitored, the baby also needs to be checked. I hope Dr. Jumoke comes back. Oh, she has disappeared. All right, so that we can now take the questions and we can take the answers. So if you have questions, drop your questions, whether on YouTube or Instagram or Facebook, drop your questions. I think technically Dr. Jumoke went off, but I hope she will reconnect back to and join us again so that we can take our questions. So today she's been talking to us about why our newborn, I mean, why do mothers have miscarriages, why do babies die, and we've gone through all that, what can happen in the early pregnancy, what can happen in the middle of the pregnancy, and what can happen even during delivery. And the most important thing, is the fact that antenatal care is important. Though most mothers will not have any problem, but you don't know who is going to have a problem. And because you don't know who is going to have a problem, we need to be ready. We need to monitor. We need to prepare. And that is very, very important. And the fact that you didn't have problem with your first two babies does not mean the third baby, nothing can happen. Each baby, each pregnancy is different. So we need to be ready. We need to be prepared. Please go for antenatal care, register in a good center. If you already have difficulties, miscarriages and all that before, it's better you register in a center that has specialists, preferably a gynecologist, obstetrician, so that they can monitor you closely. And even for your delivery, there should be a pediatrician on ground to take the delivery of the baby. And please, when they tell us, if the gynecologist, obstetrician say, okay, this is a method to deliver your baby, like have a cesarean section, there's no need for us to go and be asking from our pastor and all those other people. Please, the most important thing is that when you have a pregnancy, we have a healthy mother and a healthy baby life. That is the most important thing, outcome. Nobody wants to have a mother without a baby or the baby without a mother. So whichever way the doctors use, I believe that it is God that gives wisdom. So saying that, oh, that means that doesn't mean you are not a woman, or that does not mean you are not a strong woman, or that does not mean you are not a Hebrew woman, or whatever, all those things. No. The most important thing is that you go home with your baby. It's better to go home with a scar and have a live baby than to go home without a scar and no baby. So it's better we always, I know, adjust and follow the instructions of our doctors whenever they tell us what to do. All right. So thank you so much. I hope Dr. Jumoke will join us back, because I don't know what is happening with our network. So somebody's asking what makes a placenta to separate from the womb and how can it be prevented? I guess you're asking when the placenta separates early, because you didn't really specify at what point is this placenta separating, because normally the placenta needs to separate at the end. Usually when the baby is out, then the placenta needs to separate and come out. If the placenta doesn't come out, it's a problem on its own. That's what we call retained placenta. So I guess you meant the placenta separating before labor, or when it is time before delivery. So this is something that can happen. We call it abruptio placenta. It's a complication on its own, and most time these kind of things cannot be prevented. There are things that just happen. There are like complications, we don't know why, and they just happen. And oh, okay, thank you, Dr. Jumoke is back. I'm so grateful. Because I don't want to do this alone. I will feel more comfortable if Dr. Jumoke is there to answer your questions. Oh, praise the Lord, Dr.
Okay,
Jumoke.
I'm back. Network. I was so surprised that network even gave us 30 minutes. So when it started, I said, okay, we tried.
Thank you. So we will start answering the question. So this question, I was just about to start answering it, but I'm so grateful you're back. So this person is asking, what causes a placenta to separate from the womb? And how can it be prevented? I guess she's asking about placenta separating from the womb, maybe before the time for delivery, I guess. So what do you say to that?
All right. So when placenta separates from the womb, we call it abruption, placenta abruptio, or abruption of the placenta. You know, when you say something stops abruptly, and you know that it is the placenta that is the mediator. So the placenta is the exchange place where nutrients and everything from the mother exchange place goes to the baby. So when it separates, it's almost as if the life support of the baby has gone. So things that can cause it, sometimes it just happens, we don't know. But hypertension, when the blood pressure is very high, that can cause it. Also, trauma can cause it. Maybe the woman fell down, was involved in an accident or something. That can also cause placenta to separate abruptly. And also, when the water breaks and there is a sudden gush of that water. And that's why when we break the water, we call it we release it slowly, so that when the sudden decompression can just make the placenta to separate. So these are some of the causes. Can it be prevented? Well, hypertension, sometimes you can't prevent hypertension. Some people are prone to having pregnancy induced hypertension and all that, but the most important thing is to identify it when it happens, identify the people that it can happen in. Okay, so people with, when you have it at the back of your mind that a woman that has pregnancy induced hypertension, you are watching, you are monitoring the baby, because you know that placenta abruption is a complication of that. Also, when a woman breaks her water, rather than you check, you are listening to the heartbeat, you are listening to the heartbeat to make sure that there is no abnormality or irregularity within the heartbeat. So sometimes you may not be able to prevent it, but the most important thing is to identify it early. Because when it is identified early at time, then the right intervention delivery is the treatment as early as possible, the fastest means by which you deliver the baby. All right. So
Baby.
that
Thank you,
because
Dr.
with
Jumoke. The
abruption
next question
placenta,
is,
there are also
oh,
complications.
okay. Thank you. Sorry, I didn't know you've not finished. Okay, the next question is,
Hello,
hello, we can hear
can you
you.
hear me?
Yes, yes. Yes, we can hear you. Okay, the next
Okay, what
question,
causes blighted ovum?
yes, and how can one prevent it? We do get a lot of
Okay,
questions about
blighted
even.
blighted ovum. So, blighted ovum is just, they call it an embryonic pregnancy. So the pregnancy starts, but the baby does not develop. Okay, pregnancy starts, but it doesn't develop. So when this start is seeing a what's it called? Seeing a gestational sac, but then it is empty. All right.
Mm.
So we call that one blighted ovum, and of course, it's just because of chromosomal abnormalities. For some reason, the baby just does not form and it does not develop. Can it be preventable? Nothing per se, because it's more of something about genetic makeup, something just happening that did not make the baby pregnancy continue. Because the initial time, by the time you scan around 5 weeks, you should see a sac and yolk sac maybe, but by 6, 7 weeks, you should be able to see the fetal pole and the heartbeat by 7 weeks. But then you just don't see the fetal pole. That part that is the baby, you don't see it. What you just see is a sac. So it's usually a chromosomal thing, and it's really not preventable. There's nothing per se that you can do to prevent it.
So most of you that have got that, don't be upset or don't worry because it's not your fault, and it's something that just happened. So no need to worry. Um Somebody said, I have had two miscarriages between December and May 2021. I find out that I have fibroid. The first pregnant by 12 weeks, the fetus stopped growing by 8 weeks. I have to do evacuation. The tissue of the fetus was taken to test it. The second pregnancy was given different diagnosis, different scans within few days showed different weeks. The last show 11 weeks, but no fetus was seen, was called blighted ovum. I was told the baby didn't something for due to chromosome. I guess you are saying that, yeah, the baby didn't develop according due to the chromosomal issues, and the tissue came back with nothing. I guess that is similar to what Dr. Jumoke just explained now. The blighted ovum was because there was some chromosomal abnormalities. That's why. But you said the tissue came back, nothing was wrong, so we can't really say what really happened. All right. I thank God you are with us on this. Still a mom. I will see how we can support you. So for somebody who has had two miscarriages, Dr. Jumoke, what do you recommend for
Sorry
them?
for that. So we need to also look at it closely. You mentioned something about the fibroids. The truth of the matter
Yeah.
is that sometimes, depending on the location of the fibroids can sometimes cause miscarriages. We know that there are so many people that have conceived with fibroids and they've gone ahead to carry, to deliver their babies. But we know that
Mm.
sometimes fibroids can cause preterm delivery, they cause preterm contractions. There's certain changes that happen in pregnancy that the woman may have pain and everything as a result of the fibroids, and they tend to grow bigger, especially when the fibroids are within the cavity of the womb. When they are within that cavity of the womb, they tend to compete with the fetus. The space where the fetus is going to stay. When you have a submucous fibroid, for instance, that could pose a challenge and that could actually cause miscarriages. So it is number one, we need to assess that fibroid again. Where are the fibroids? All right. If it's within the cavity of the womb, then you may now consider removing it. If it is within the cavity, if it is still within the womb, what we call the intramural fibroids, how big are they? Because sometimes when they are actually very big, they may compromise things. So if the fibroids have to be assessed, also they have to look at other things. They have to check your sugar, do oral glucose challenge test to make sure that it's not as if you are in the diabetic range. Also have to check your thyroid, you understand? They also have to assess your womb. Is there any congenital abnormality that is just causing some of these things? All right, within the cavity of the womb. So you need to go for an assessment. And this assessment is done when you are not pregnant to try to see so that they can prevent it. Sometimes some people have things that we have called antiphospholipid syndrome. All right, there are other causes, autoimmune causes. So they have to investigate you. You need to see a gynecologist that is interested in this kind of thing. Some people have a passion for treating people with miscarriages and everything. So you need to look for somebody that has that kind of passion, all right, or is so specialized in that area so that they can actually look. The reason why we're looking is to try and see whether there's anything that can be done to prevent further miscarriages. Because we've talked about the autoimmune thing, and the autoimmune thing is relatively new in the system. Sometimes some people don't believe that autoimmune conditions cause miscarriages, but they are real and they're a cause of infertility and sometimes miscarriages, recurrent miscarriages.
Yeah. Thank you, Dr. Jamaica. Let me just quickly answer this question on Instagram. Ruth Stitches said, Doctor, what's the cause of sepsis in a newborn? Yes, because sepsis can also cause deaths of babies, and we're still talking newborn deaths. Um, when you are pregnant, most newborn babies, the womb is supposed to be a sterile environment for them, as long as the what do you call it, Dr. Chubake? The lining of the womb, that amniotic
The
membrane
amnion,
is that.
the amnion.
Yeah, the amnion, the membrane is intact. So as long as it is intact, that baby will not have any infection as much as possible. But if you as a mother, you have some infections, like Dr. Jumoke mentioned, what we call the touches, like totoplasmosis and rubella, cytomegalovirus, these are, most of them are viruses. If you have it, they may not disturb you, but you can pass it to your baby. But most of them just cause some other kind of issues in the baby. Baby may not grow well. Baby may have jaundice when they are born and all that. But the commonest cause of infection in babies during if the water breaks, like that membrane is broken, germs from the genital area, germs from anywhere can enter into the womb, and it may cause infection for the baby. And that is why Dr. Jumoke team will, like, once you have broken your water, as long as it is they may want to give you antibiotics, or they may want to deliver you early, because it's not just about especially if you're already close to term, it's about making sure our baby doesn't get infection. Then during the delivery itself, the delivery process has to be as clean as possible. If it is not clean, and this is why we say you should deliver in a good center, who know where they wash their hands, where they use appropriately, so to make sure the environment is clean. Because once the baby is coming out, if the baby is landing in a very dirty environment, hand of people touching the baby not washed, that baby can be exposed to germs. And babies, when they are being born, their immunity is very low. They have not been exposed to any germ, they've not fought anything, so they have very low antibodies and all that. So they are not able to really mount um lots of what we call, most of us, we are exposed to germs, but the only reason why we are not having infections is because our immune system is fighting them. So newborn babies don't have the ability as such. They have it, but it's still immature. So we need to protect them from germs. And this is what we mothers in Nigeria, when you have a baby, the whole village come to visit you, and everybody wants to touch baby, everyone to carry baby. It is wrong, because they are all coming with their germs that is not disturbing them, but they are exposing the baby to that germs. And that is why we say clean environment, clean delivery, people touching the baby, even you as a mother, washing your hands with soap and water. I think uh, coronavirus has taught us about hand washing now. It's actually what we should have been doing all along. Actually, when you want to touch your baby, please wash your hands with soap and water. The healthcare worker, if you deliver in the hospital where the nurse keep going around with one hand touching all the baby, it's also one of the ways babies get exposed to germs. So when they come around, they must wash their hands or use at least hand sanitizer, so that the germs from another child doesn't come to your baby. And of course, general care of the baby, breastfeeding, exclusive breastfeeding, gives baby some immunity and all that. So these are the things. So for roots, basically, when baby is exposed to germ, the baby must have been exposed to germ either in the womb, or shortly after delivery, or during the delivery process, or even after the baby has gone home. So those are the ways by which baby can get exposed to germs. If the infection occurs early, we call it early neonatal sepsis. For example, some mothers have some germs, what we call group B streptococcus in their vagina area. It doesn't disturb the mother, but when the baby goes through that jam area, the baby can have what we call sepsis and all that. And so those are the ways. So what the obstetrician does is they normally clean the vagina area well before the baby comes out, And so this is especially for those of you who deliver at home, who deliver in CBA churches. Some of this prevention may not be taken. And when babies have sepsis, they may not always have fever. It may be as simple as baby not wanting to feed. It may be as simple as baby not being active and all that. So if you see any abnormal signs at all in a newborn baby, please take to see a pediatrician. And newborn babies can only be managed by pediatricians. I don't want to take newborn babies to general doctors, because they are not very they may not be able to handle them. At that age, they are very, very fragile. Any baby less than 2 months, they are still very, very fragile and should be managed by the pediatrician. So the earlier you go to a hospital with the pediatrician, the better, because sepsis is also one of the reason why babies die. In fact, that first 1 day of life, that first week of life, the first 1 month of life is the most dangerous part of your lifetime. So the danger in your first month of life, most babies die in their first month of life, and most of those ones who will die in the first month of life die in the first week of life, and 3/4 of those who will die in the first week of life die on the first day of life. So those days are very crucial that the babies are properly managed and monitored. So I hope that's helpful. Okay, I can't see any more questions on Instagram. So if you have questions, please drop it. Dr. Jumake is here. Um, Thank you. Okay, somebody is asking, Tisilokwe is saying, can sneezing cause placenta to detach during pregnancy? Can sneezing cause placenta to detach? Is that possible, Dr.
No,
Jumake?
no, 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 no. Sneezing is a normal process. Reflex space. Then no, it doesn't cause placenta to separate.
All right. Okay. Thank you, Ikeo. Yes, we are doing well. Thank you. Jane is asking, please, what are the causes of premature labor? I mean, number one, what is premature labor, Dr. Jumake, and what are the causes of premature labor?
Okay, so let's say premature labor is different from premature contractions. Of course, when labor, the onset of labor before term, meaning when labor starts before term. And when we say labor, we're saying that the woman is contracting and also the cervix is beginning to open. All right, meaning that baby is prepared to come. There are various causes of preterm labor. Okay, sometimes some people there are risk factors for preterm labor. For instance, when we have very young mothers, all right, less than 18 and everything. Also, when people are from the low socioeconomic group, all right, not in exposed to poverty and everything, that can predispose to preterm labor. Also, the fact that people carry multiple pregnancies, twin pregnancies. As much as we love twin pregnancies in this part of the world. They are, we know that they are number one cause. Is it? I mean, it is known that babies, people with multiple pregnancies, babies tend to come early, and so the more the babies,
Yeah.
the higher the risk. So when it is twins, about 36 weeks on the average. When it is triplets, it goes lower to about 33 weeks, and when it is quadruplets, it could just they become as early as 31 weeks. So these are some of the risk factors for preterm labors. Also, infections, your simple malaria, okay, can predispose to preterm. Any infection, urinary tract infection. That's why sometimes they check your urine just to make sure that um, um, what that is it's free from infection. Latest one that we are the pandemic COVID-19 also has been linked to preterm labor, because it causes fever and everything. Anything that will spike fever and all that can predispose to preterm labor. So anything, even stress, you understand, the woman going through plenty stress, physical and everything, all these ones too can predispose to preterm labor. So, and of course, somebody that has had a history of preterm delivery is prone to it. If some people, their babies come early, they'll say, "Oh, I usually have my baby 36 weeks, 35 weeks, and everything." So, if you know that you are predisposed to preterm delivery, then you should register in a place that they have very good neonatal backup. Sometimes we are not able to, of course, there are medications that are given to try to, when, because it doesn't just, it starts with contractions, it doesn't just progress like that to preterm labor. But when a woman starts having contractions and everything, then we can try to abort the contractions, but sometimes we are not that successful and it progresses to labor. Also, people having fibroids coexisting with pregnancy, especially when the fibroids are a lot and everything, this can also predispose to preterm preterm delivery, preterm labor stroke preterm delivery.
Okay, so I guess if you have the risk factors, all those risk factors Dr. Jumoke has mentioned, then you should be seeing your gynecologist frequently. And if once you go into what look like preterm labor, then you really need to go to the hospital fast, so that if they can do something about it, they will. If not, we want the baby to stay. Pediatricians, we want the baby to stay in the womb as much as possible, because prematurity is one of the leading causes of our neonatal deaths. Baby being born too early, being born too before, just like she said, any baby born before 28 weeks is our hand on our chest and we are hopeful. Usually from 28 weeks, we are a little bit better, but then the care is so expensive. Incubator care is so expensive. So we want that baby staying in the womb to 37 weeks if possible. All right. So somebody is asking, what causes babies to have diabetes? What causes baby to have diabetes upon birth? Why the baby mother's sugar level is normal? The mother did not have gestational diabetes while pregnant. Okay, the baby have diabetes? Who told you your baby have diabetes? Okay, Dr. Jumoke, do you want me to answer that? Since it's a baby question.
Please go
Okay, so
ahead because question. Mhm.
okay, so I guess maybe your baby's blood sugar was high. Maybe then when you say a baby, okay, after birth, okay, so your baby's blood sugar was high. Okay, so if it's a newborn baby whose blood sugar is high, the number one reason for that is sepsis, infection. When babies have infection, their blood sugar is going high. It doesn't mean the baby have diabetes, because we are very, very particular about terminologies. The fact that your blood sugar is high does not mean you have diabetes, because diabetes is a condition, it's a lifelong condition. Once you have it, you have it. But a baby's blood sugar can shoot up, usually when they have infections. So, and even for preterm babies as well. So, we monitor the blood sugar very well. And if the blood sugar is high, it may be telling us that this baby may be fighting sepsis, or the baby may, if it's a preterm baby, also, it may be that whether we have been giving too much of the if your baby is on drip, maybe we've been giving too much of the of the glucose. We caused it iatrogenic, or but the commonest reason why most babies have high blood sugar is is infection. It is the baby does not have diabetes. I need to correct that. The baby's blood sugar is high, but that doesn't mean the baby have diabetes because we can control it. Once we treat the infection and we give the necessary things, the sugar will come down. Then we keep monitoring it. So if that is what you are asking, I want you to let me know if that is actually what really happens, so that we'll be clear on that. All right. Thank you. D. Israel say, what causes the death of twin babies after delivery? Okay, so D. Israel, you should have told us how many days after did the twins die? How preterm were they? Like, when were they born? Because Dr. Jumoke already told us that twin babies die pretty, sorry, not die, that twin babies are born early, preterm. So, were they born preterm? And so it is difficult for us to answer this question because you can't just, number one, twin babies don't just die. Twin babies are not supposed to die. That is, if that's the question. So you really need to tell us what happened with these twin babies for us to know what causes their deaths. Were they born preterm? Were they sick? How old were they when they died, and all that? So it's better to give us those kind of information than to just ask. We are not magician. We don't have that. So we can't really say what causes death of these particular twin babies because we don't know these twin babies at all. But I can assure you that most twin babies don't die. Most of them live. We have a lot of twins in Nigeria, so you should know that twins survive. So if they were born too early, or their weights were small, or they have complications, then we can explain that. I don't know whether they are the same twins that have jaundice. You didn't say. So yeah, what causes jaundice in babies? That's a whole topic on its own. If I go into that, we'll not finish the program. So I think it's better we restrict ourselves to the topic of today, which is why our newborn babies die. Anyway, jaundice can also cause death of babies if it's a very severe jaundice and we didn't treat it on time. So it can cause the death of the babies as well. So the Israel, I guess you may want to repost your question to make it clearer because the way it is now is too generic and we can't really answer it that way. All right, G is asking, why does he, at the beginning of 9 months, why does he feel like he's out of place with serious pain that one cannot walk? Okay, Dr. Jumake. And is it possible for a woman to be in labor without the baby, to be in labor without the baby not contracting? I mean, that the baby is lazy to contract. It's not the baby contracting. I think it's the uterus contracting. Okay, Dr. Jumake, this is for you. Dr. Jumake, are you there?
You've answered. It's not the baby that contracts.
Oh,
It's the womb that contracts. The baby is the baby. You didn't phrase the question very well. Maybe she was trying to say, is it possible to be in labor and not have pain?
I know
Maybe,
have
some
contraction.
people, again, pain is a relative thing. All right, pain is a relative. Can you hear me?
Yes, we can hear you
Can you
now.
hear me?
Yes, please.
Hello, can you hear me?
Yes, yes, we can hear
Okay,
you.
so there's some cultures where, okay, there are some cultures where the woman that by the time she shouts in pregnancy, when she's in labor, something happens. So they tend to do well, very well when they're in labor. All right. So maybe she was talking about, is it possible to be in labor without contracting? You will contract, but some people may not feel the contractions as much as other people feel it, I guess. Now, you said at the beginning of 9 months. Is it at the beginning of 9 months that your hip feels out of place? As the pregnancy advances, the weight of the baby can press on certain nerves, okay, and that can make you have this hip pain because it's actually compressing on the nerves. But once you deliver, it tends to get better. So I don't think, I think you should reframe your question, G, because it is usually as pregnancy advances that you tend, with the compression of the baby's head compressing, or the weight of the baby compressing on the nerves, on the hips and everything, then you may start having pain. Or sometimes because of the pregnancy hormones, the pains, the joints tend to be more relaxed, the ligaments and the cartilage tend to be more relaxed, and then sometimes people may have some musculoskeletal pain. So that is what I understand by your questions, but certainly not at the beginning of pregnancy.
No, she said at the beginning of 9 months. She's talking about the 9 months of the pregnancy. So yeah, you are right. You've answered that question. Thank you. Let me just take a few questions on Instagram. Daddy Isio is saying, thank you for your time. Does having a colostomy slow down the weight gain in a baby? Okay, your question is not really related to our topic, but there's a reason why a baby has a colostomy. A baby who has a colostomy most likely has an abnormality in the intestine, maybe some obstruction or something not being properly formed. So they have to bring out the intestine while they are waiting to address whatever is the abnormality. So that abnormality itself is the reason why that baby may not be gaining weight. It's not the colostomy. The colostomy is just a procedure, but but that baby already have a problem with the intestine. So a baby who has problem with the intestine may obviously have difficulty with digestion, absorption, because that is the job of the intestine. So that may be the reason why the baby is not gaining weight. But I believe that if your baby is having a colostomy, your baby will be seeing a specialist, pediatrician, pediatric surgeons, dietitian, nutritionist. So please talk to them and they'll be able to tell you how to feed the baby. Those are the kind of babies sometimes we have to give them extra supplements and things like that. All right. The next question is, Doctor, from what week do we consider a baby preterm? Okay. From what week do we consider a baby preterm? That's 37 weeks. So any baby born before 37 completed weeks of gestation or pregnancy is referred to as preterm. So some babies are like 36 weeks. We call them late preterm. They're almost 37. So they are close to, we call them late, but they are still preterm as long as it's not 37 weeks. But babies that are born early, less than 20, is it less than 26 weeks now? We will call them early preterms. And between 20, no, I think it's
No, our viability is 28 weeks.
okay, so
Our viability is still 28 weeks.
yeah, even though our
So
viability is
anything,
28 weeks,
unfortunately, anything less than,
sorry, I was saying that even though our ability is 28 weeks, any baby born life, we will still take it as a baby. We will not say because it was not
yes,
born.
yes, as a baby,
We've
yes,
had
yes,
24
yes.
weekers. I think our best baby that survived when I was in Lutz was a 24 weeker. I can't remember whether we have anybody less than that. I need to check the record. But we've definitely had 24 weekers surviving, 600 grams surviving, 700 grams surviving. Yeah, we've been able to keep them alive long enough. Okay, so yeah, don't let me not go into the classification, but any baby born less than 37 weeks is okay. Tonya said I didn't read your question. I can't see your question. Let me just scroll down a little bit. Maybe I mixed it when I was scrolling up. Sometimes I always miss out some of these things. Sorry. But let me just do it gently and be sure I missed out your question. Okay. Etonia, do you mind repeating your question? Because I can't see your question. Okay, I can't find your question on Instagram. Do you mind repeating the question and I'll promise to answer it before we close? No, I can't see your question. So please repost your question, Etonia. It's not on Instagram. Maybe it didn't drop. Okay. Tonya, the trip store. I didn't see any question from you. So please repost the question. All right. Okay, we've answered this one. When can one start trying again? Yeah, Dr. Kimaka, this is a very important question. Mothers ask this all the time. They've had a miscarriage. When should they start trying again for a new baby?
The truth of the matter is that you can start trying immediately, meaning that after the miscarriage, if you've had an evacuation, everything, and your period returns, you can start trying. There is no hard and fast rule, so there's nothing stopping you from trying immediately after the
The baby. Okay, the miscarriage. Okay, what about Dr. Jimake? Are you still there? Dr. Jimake? Come back. Oh, don't disappear. Okay, Antonia saying you are asking why the upper walls of the mouth peel in kids. Okay.
miscarriage. But however, some yeah. So I'm back.
Oh, thank God.
Sorry, I
So
didn't get the question. You said
no,
you
no, don't
said what
worry.
about?
What about those who had cesarean section? The people that lost their babies after late
Okay.
pregnancy, and maybe the baby was born, or maybe they had a cesarean but the baby still didn't make it. When can such mothers start to try again for a new
Okay.
baby?
Well, usually standard, you say for cesarean section, you want at least 18 months before they start trying. But it's just to make sure that the scar, the healing process has taken place, everything has returned back to normal. And of course, the closer, how will I say, when the interval is shorter, the tendency for you to have a repeat CS is higher. However, we also have to balance things. When somebody, for instance, is the first child, they just they lost the first child and everything. You are not going to. Sometimes it's. I don't think they can start trying after 6 months for me, if they don't have any child, or for instance, if the woman is already in her late 30s or early 40s. I know that as she gets older, also the fertility may start declining. There's nothing wrong in starting after 6 months. And then all you just know is that when she gets pregnant, she will need close monitoring and everything. So basically, I guess it should be okay after 6 months to start trying, because it was a cesarean section. But there is no law per se, or it's not sacrosanct. You understand? I mean, people can. I've seen people that get pregnant after 3 months of cesarean, but on the average, you just say, okay, just wait after 6 months and then start
Yeah.
trying. But like you said earlier on,
Mhm. So Jamaica has disappeared, or your internet has disappeared again. Okay, so Dr. Jamaica is saying there's no law. You can start trying as soon as you are comfortable to start trying. Trying to see whether Dr. Jamaica will come back. Okay, while she's coming back, Etonia is saying, why did the upper walls of the mouth peel in kids? Okay, I actually today's is about antenatal and miscarriages and newborn births. So I try not to answer that question, but I'll just quickly answer it since you waited for it. There are many reasons. It could just be as simple as the fact that the baby is they are dehydrated, or it could be from vitamin deficiency. And so what, or it could be dry weather, like weather can make your lips to peel, what we call chapped lips. So what you just need to put Vaseline and all that. So I make sure the children are not dehydrated, they drink a lot of water. So if there are other things going on, then you if there are other signs and symptoms, then you need to see a doctor as well. Okay, so I hope that is helpful. It's not normal for baby lips to peel, so it is not normal. So if it is peeling, and make sure if it is whitish kind of peeling, because you have to be sure it's not oral thrush. So I'm answering your question the way you posted, because it didn't really specify whether it's whitish stuff or not. So that is important to clarify that. And then the next question, of the mouth. When you say mouth, where which part of the mouth? The lips is part of the mouth. You really need to be very specific. At what time can you start using Infacol for colic in babies? When the baby has colic, you can use it when baby has colic. Baby doesn't have colic, there's really no need to use the Infacol. So when your baby has colic, then that's when you, yeah. So if you're asking for the gum, if the gum is peeling, you need to see the dentist. It's not normal for the gums to peel. So gum is not mouth. So if the gum is peeling, then you've got to see the dentist, because that is a different thing altogether. All right. I hope that is helpful. I hope Dr. Jamaica has come back so we can yeah, Dr. Jamaica is back. All right. Okay, so Dr. Jamaica is back. Let me put back my okay, thank you, Dr. Jamaica. We will survive. Don't worry, we're almost done now. We have just about one or two more questions. Is there any medical reason for having is there
okay.
any medical reason for having babies 3 weeks after EDD? What do you mean by 3 weeks after EDD? Okay, you mean your EDD is 40 weeks, then you have your baby at 43 weeks. Okay, Dr. Jamaica, what's the answer to that?
All right. So, well, how will I say? we there's a place for we call it prolonged pregnancy. All right, once your pregnancy passes the dates, okay, but we allow for 42 weeks. So first of all, let us be clear about your EDD, because we all know that sometimes you may not remember your last menstrual period, or we also know that the most accurate EDD LMP is the one, the scan you did during your first trimester. During your first trimester. As pregnancy advances, second trimester, third trimester, the accuracy of the scan is that you find out that EDD begins to widen. So it's usually the first scan, the first trimester we use to estimate when you don't know your date. However, on the average, average pregnancy is 40 weeks, but when we say term, it gets 42 weeks. However, after 42 weeks, most people will want to deliver you. So I'm not sure most doctors would have left you for 43 weeks. There must
Yes,
be,
so
maybe they were not
yes.
convinced about your EDD.
No, the
However, in
mother
this
even
environment,
go to the hospital.
around
Some
that
mothers even
41,
go. Some
yes,
mothers
true, but
even
I'm
go to
almost so sure
hospital.
she's also not
They want
sure
to
about her
deliver.
EDD. I'm sure
Yeah.
also sure she's not sure. But usually on the average in this environment, it is 41 weeks we like to deliver, because we know that the older, we also have placenta insufficiency. You understand, the baby is getting old, and things may start decompensating. But in Western world, sometimes they will give you to 42 weeks, but monitor closely. During antenatal CTG, if the baby is fine, they will just continue, and at about 42 weeks you will be induced. All right. So sometimes some
Yes,
pregnancies
I
are
just want
just
to. I just
prolonged, all right, and some also have been associated with. Go ahead.
no finish. That's the gap. Don't worry, go on.
No, you can, and then some congenital, when the fetus with some congenital abnormalities, it has also been associated with prolonged pregnancy. Now I can't remember which congenital, but it has been associated with a prolonged pregnancy. But some people just have it, and especially when sometimes when it's your first pregnancy and all. But usually after 42 weeks, most people will terminate it. But in our environment, 41 weeks plus will induce you.
Yes, so I was just going to add that please, once you have passed your EDD, go to the hospital. Don't wait to fall into labor. This happens because some of you don't go for your antenatal clinic because at that time I believe you should go into the hospital every week to see for your antenatal care. And then you should let some of you are none of you are not going for proper antenatal care. You just go to hospital to deliver, maybe you didn't even you are not been going for regular antenatal care, because if you are going for regular antenatal care, your doctors will be making plans for delivery already. So one of the reasons why some mothers lose their babies is because of this. Because you wait too long for the baby, and baby sometimes could, placenta insufficiency, baby could pass on. Please, once you are 40 weeks, labor or no labor,
Basho,
go, go to your
let
doctor,
him
go to the hospital, and let the
mention
doctors take a decision about delivery for you. All right. I hope that's helpful.
after
Okay, yeah, still with us. Let me mute your mic for you. Um, Okay, the next question: what's the normal weeks for delivery of a single sim baby? Normal baby delivery is 37 to 42 weeks. So most doctor will give you a date that is 40 weeks, but you can deliver 2 weeks before, you can deliver 2 weeks after. But what we just said based on the last question is that we don't want you to deliver beyond 42 weeks because the risks of your baby dying is higher after 42 weeks as well. So I hope that is helpful. All right. Jane Oko. Dr. Jumake, are you back? Jane Oko is saying, what is the normal range of PCV during pregnancy? Dr. Jumake, what PCV do you want during pregnancy?
all right, in this environment, 30%, it should not go below 30%.
Yeah. Okay. We want it
In this
not less than 30.
environment, it shouldn't go below 30%.
All right. Thank you. The next question, we're trying to rush up because I think we should round up. What should one expect labor When should one expect labor? Okay, I think you are just asking the same question in another format. The same answer you've asked with the normal weeks of delivery is still the same thing. When should you expect labor? Labor can happen anytime between 37 to that 42 weeks. Okay, but we're saying that if you are 40 weeks, which is your date, and you have not delivered a baby, please see your gynecologist so that they can start planning. Some of them may give you up to 41 weeks to see whether you will fall into labor. Depending on whether you have other issues, the doctor may want to deliver you early. For example, if you have diabetes, they may not want you to go past 37 weeks or 38 weeks. So the delivery of your baby is not just your decision. There are lots of decisions around it, and it is in decision. That's why you should go for your antenatal care, and the gynecologist will decide for you when you should. Okay. Facebook user, I said to prevent my question, one can start trying after loss of baby at 18 weeks. Is it pregnancy that if it's pregnancy loss at 18 weeks, it's still the same thing. Dr. Jumoke said there's no fast rule. Start trying immediately when you are ready. As long as it's a pregnancy. If it is CS, you said you can make it 6 months. Like if you have had a baby and it's baby was you had a cesarean section, then you can start trying maybe at least 6 months. But there's no law. You can start trying anytime you're ready. Okay. Facebook user say I gave birth to my baby at 31 weeks through cesarean, but its lungs were not fully developed. Please, doctor, what can cause that? Nothing caused that. Baby is not yet ready. I mean, 31 weeks, baby's lung is not yet ready. That's all. It's not like it's caused by something. That is why the baby should have stayed in the womb to 37 weeks so that the lungs could mature. So nothing is causing it. It's just because your baby was born too early. So the lungs have not yet fully matured. So what we normally would have done, if we had enough time, maybe your doctor has to do an emergency cesarean section to save your life or the life of the baby or both. But if not, assuming your doctor have a little more time, we would have given you steroids. The steroid will quicken the maturation of the baby's lung. So sometimes for babies that we know that they can be born too early, usually, I don't know, Dr. Chumake, when people start to try them on steroids, we can give them steroids early as well and to mature the lungs. But if your baby was already born, because we don't have enough time to give you steroids, we have what we call surfactants, which can be given to your baby. It's very expensive also in Nigeria, but most neonatologists could also try that. I hope your baby made it. You didn't tell us. I hope just let me know whether your baby make it or not. But I hope it does. So it may give baby what we call respiratory distress syndrome because the lung is not mature. That's why we want baby to stay in that womb till 37 weeks. Okay, this person is asking this question. I think Dr. Jumoke has answered this question. Is it possible for a mother to be in labor without pain? I think you've answered that. And if that happens, is there any danger if that happens? Do you want to just recap it again? Because I think you've answered it already.
Well,
Oh my God. I need to.
we said that will escalate the pain. Some people can danger to it. There's no danger to it. If you don't feel pain, you don't feel pain. It's not as if it will harm. But in some cultures, they will tell you that if you shout too much, it will harm your baby. There's nothing like that. They'll say if you shout too much, it will harm your baby. There's nothing like that.
But I think that's what I would want to add is that if you are in labor and you don't feel pain, it's because if you don't know you are in labor, you may not want to go to the hospital. So that's the problem. Because if you have seen your water or show whether you feel pain or not, I think it's better you go to the hospital because labor is not just contraction, it's also dilation of the cervix. So they need to check that you are dilating.
The few people I've even seen, they come to the hospital themselves, but maybe they become at an advanced whatever, but they also feel something unusual. They actually still feel something unusual and they may feel pressure. So you will always feel something unusual. Maybe not like the excruciating thing that people would think, but you will always feel something unusual, that something is not right. Maybe baby is about to come, that will make you think, I think I need to check myself. After all, you are already term and you are probably expecting the baby and then labor to start.
Okay, so please, if you are in labor, whether you feel pain or not, go to hospital. Remember what Dr. Jumoke said at the introductory part. They need to monitor labor. Things may be going well, but things may go wrong, and we never know when things will go wrong. And for us pediatricians, we need to be there with either the nurse or the doctor or the nurses. Somebody needs to resuscitate baby. Not every baby is born crying. 1% of babies will be born not crying, and we need to help those babies to cry. So we need to make sure that they breathe. So this is why somebody must be delivery must be supervised. I know that some women, some culture always have their babies unsupervised, but I think it's also one of those cultures that have the highest number of newborn deaths as well. But they also have this belief that okay, it's God brought it, God has taken him. But when you have a baby, the baby needs to be checked. So it's not enough to just have a baby, the baby must be alive. And sometimes it's just that first minute is so crucial for the baby to cry. And it is not slapping the baby or eating the baby that makes baby cry. We just need the baby to breathe. So please, rubbing the baby gently and all that is something that everybody should actually know what to do. But at least all those who take deliveries, pediatricians, midwives, nurses, obstetricians, we all need to know how to resuscitate babies. That is very crucial. So if you're in labor, please go to the hospital. Oh. Don't stay at home so that we can do the right thing. Okay, so the Israel is giving me more information. Baby were born at 28 weeks. Husband is so, mother is so positive. Husband is being negative. Does it have any effect on the baby? If the mother, as long as the mother is not the O negative, there's no problem as far as resource is concerned. There is still what we call ABO incompatibility because the mother is O. Any mother who is O, there is what we call ABO because the husband is B. If those babies are B, they could have jaundice from what we call ABO. There are many reasons why these babies could have jaundice. Number one, they are premature babies. So prematurity itself is a cause of jaundice. Number two, the mother is O plus OO. Any mother who is O and your baby is on other or otherwise not O, your baby could have what we call ABO. And ABO jaundice can also be very severe. So this is a double-edged cause of jaundice for these preterm babies. Any baby born at 28 weeks is still a 50-50. You didn't tell us the weight of these babies, but the baby's risk,
No, no, let him. No, I don't.
the cause of death in babies is the number one cause of death in newborn babies is prematurity. So these preterm babies were born at 28 weeks. It's already 50-50. Now they also had jaundice from prematurity, from ABO incompatibility. Risk is higher. What kind of care did they receive? How early? What is their weight? Were they less than 1 kilo? Any baby less than 1 kilo is also 50-50. So the risk of death in this any preterm baby is very high. So that may explain why the baby passed on. So sorry about that. Yeah. So that's why we don't want them born too early. All right, I guess we've answered all the questions, Dr. Jimake. Thank you so much. I think we've answered. I hope there's nobody on Instagram. Okay, Chanel say if you had your first child through CS, will you have other children through CS? Not necessarily. It depends on why you have cesarean section. So if you have a cesarean section because your cervix is small, or you have what we call okay, Dr. Jumake is back. Let's answer that one. If you have cesarean section for your first baby, will you always have cesarean section again? Dr. Jumake, did we get it?
No, no,
No,
no.
no.
It
Okay,
doesn't
yeah.
mean that once it's yes, it doesn't mean once a cesarean, always a cesarean. There's room. You can have a vaginal birth after cesarean delivery. So there are a lot of factors we'll look at before we decide before the decision is taken. But it doesn't mean it is not a rule that once you've had a cesarean section, then all your subsequent deliveries will be cesarean deliveries. The reason why you had the CS is, for instance, is one of the things would if it was like, oh, baby was tired, baby was distressed, you had an emergency and they quickly just had to deliver the baby as fast as possible. It does not mean that will happen in the next pregnancy. So no, but if you've had a cesarean delivery before, it does not automatically qualify you for subsequent cesarean deliveries.
All
Not
right.
anymore.
Not
So there are
anymore.
other factors we look around, but a decision will be made.
What about after two cesarean section, Dr. Jumoke? Will you say will you now
Well,
qualify like
after two
life
cesarean
dinner?
sections in this environment, after two cesarean sections, you will have a repeat cesarean delivery. After
So
two, but after
after
one, it does not mean
because I've seen people told
yes.
me that they've had two cesarean, three cesarean, then they still have a normal delivery. And I tell them, no, it's not
They want
possible. Please don't. And then, how many cesarean sections can
well,
you have in hall?
so some people have had
Oh,
no
your
cap
inter-
to it. Advise you to have a tubal ligation. We advise you to tie your tube so that you don't get pregnant again. Usually after 4. But by and large, with good education and everything, people stop at 3. Stretching it will be 4. After 4, we really don't like doing anymore. But there is no cap to it. There are people that, well, literature has record of people that have had over 4. But
five, yeah.
usually in this environment, after 4, we advise you to have a tubal ligation done
So please,
so
after two
that you don't put
cesarean
yourself at risk.
section, yeah, some didn't hear you well at a point. So after two cesarean section, please plan for cesarean for the rest of your deliveries. And after 4, in fact, 3, from 3, start planning not to have more. By 4, please let it end there. Let's not put our life at risk. Women will keep putting our life at risk. And especially those of us that are looking for male children. This is 21st century. Every child is the same, whether you have male or female. You can put whatever name they
Female.
want. If you want to carry their father's name, they can carry their father's name and join it to the husband's name. So all those nobody to carry on name, that era is gone. People even bear their maiden name even when they are married, so there's no story again. No, please don't put your life at risk because you want to bear male children. And if you want to have male children, yes, it's just about your money. They can do IVF sex selection for you. So see Dr. Jumoke and our team in camera, they will sort you out. Okay, I think we got to go. We got to go. I just oh I just okay, let's just take this last two, then we'll go because people will not allow us to go if we keep on going on. At 37 weeks, I have some evidence on my lower back. I went to the hospital and I was almost turned down. The evidence was unusual and I had it for 6 hours. So does it warrant a CS? I don't know. Why will you need a CS because you have evidence at your back? Is it a form
Yes.
of labor?
Yeah, the question is not straightforward.
It's not clear. What's the name? Olamide, your question is not clear. We're not sure what you are asking us. Did they do a cesarean section for you because of that evidence, or did they say you're in labor? Because usually, when you, if no matter what you feel, they will examine you. They will do a vagina to know whether you are dilating or not. If you are dilating
Oh,
and they've planned you for an elective CS before for any reason, then they will do it. So if they're not planning for an elective CS, I don't think they will just do a CS. You need to give us more
yes,
information
please.
if you want us to answer. What causes dizziness at 3 weeks after giving birth? Okay, is that for Dr. Jumoke or for me? I think it's for Dr. Jumoke.
Anything can cause dizziness. Anything can cause dizziness. Plenty things. You could be stressed, your blood level may be low, you may be hungry. There are so many causes of dizziness. So we need to
Hunger,
find out why. Yes, you are feeling dizzy. You may have
please.
breastfed and you have not
Eh,
been eating well, and then you now start
eh.
feeling dizzy. So there are so many things that can cause dizziness.
I
So
always tell
we need
them,
to
don't try to
complain.
lose weight when you just had your baby. Please, that's not the time to start losing weight when you are breastfeeding. You can eat sensibly, but that's not the time to start starving yourself or trying to take all these pills for weight loss and all that when you are still breastfeeding. Just wait, exercise, eat, portion control, but don't be very active with your, because this that may be the reason why you're also dizzy as well. Then we need to check your blood level as well because some women lose blood in pregnancy. And I think usually they will normally check their blood before discharge, but not all hospitals do some of these things. So we don't know. Maybe your blood level was low. So just check with your doctor if you are dizzy. Please check with your doctor. Some people can even have high blood pressure even after delivery. So there are many causes like Dr. Jumoke said. So check with your doctors. Thank you, Dr. Jumoke. We've gone beyond Our usual time.
Thank God, and thank God for the network that we were able to do this,
Wow,
because
this
I
is the
was
best. This
thinking
is the best we've had so far. I hope we can have it at least once in a month. We can have Dr. Jumoke or any
um,
of our
by
colleagues
the grace of
with
God.
us to answer, because I think mothers always want to know why. So sometimes, like as you have had today, it is not your fault. Sometimes these things happen. Yes, but we still understand. We understand. But the ones we can do something about, like Dr. Jumake has said, I think we can summarize it to antenatal care. Antenatal care. Do the one you can do, and let's leave the rest to God. And please go to a good center. I always tell, if you are not sure what's a good center, the government hospitals, at least from the general hospital to the tertiary hospital levels, usually have good specialists. There are also very good private hospitals with specialists. But if you are not sure, at least if you go to the general or tertiary hospitals, you will always have specialists. Not everybody needs specialists. Most of us need just midwives. But if you have had all these challenges, many miscarriages, many of these, it's better you go with the specialists. Or child deaths, it's better. I've had cases of my parents that they suffer one challenge with the one pregnancy, went to another hospital, suffer another challenge. So I always say at that level, you really need to be with the specialist so that's not to cause that anymore. All right. So thank you so much, Dr. Chumoke. Thank you so much,
Thank you for
everyone.
having me. The maiden
Thank you so much.
edition. Thank you.
Thank you, Instagram family. Thank you, Facebook family. And if you have suffered a child loss or pregnancy loss, or you know somebody who has suffered it, you can let them know that we have a support group now on Facebook called ATP Still a Mom. You are still a mom, whether you have the baby, that baby as it's a living being. Even though the baby is no longer with us, you're still a mom. So don't feel like, oh, I'm not a mom. You're still a mom. And we are there to support you. So we have people that can give you counsels, who can just listen to you. We have professional counselors, psychologists who can, if some women go into post depression and all those kind of things. So if you need support, please join that Facebook group. No judgments. We're just there to support you. If you need medical support as well, we can point you in the right direction. And of course, we will have program like this when we have our specialists also give you advice on how to not to experience that in future. But please come refer them to the group and we will try and support you. So thank you all so much and have a blessed weekend. Dr. Jumake, thank you so much for your time. We really appreciate. I know you're a busy woman, but coming back
Thank
from work, we
you.
didn't allow you to rest and you are still here with us. We really appreciate your work. And Dr. Jumake has a book. She has a book on Beyond nine
Thank
months and beyond. So if you want a book, please reach
you.
out to
9 months
me.
and beyond.
Yes. Where can they get the book, Dr. Jumake?
It's on
Dr. Jumake.
Amazon, and they can get the
Okay.
hard copy. They reach out. It's on
Yes. Okay.
Amazon,
Soft copy is on Amazon. 9 months and beyond, Dr.
and the hard
Olajumoke
copy
Ogunro. But if you want hard copy, reach
they
me, send me a
can.
message, or send Dr. Jumoke as well. You can just reach out to us anyhow, and then we'll make sure you get a copy. So because that book is a book every mother should have. It tells you what to do before pregnancy, during pregnancy, after pregnancy, even for the baby. There's a chapter for newborn because I know that one because I was part of that. So please, you need to get a copy, and I'm sure you will love it. It's not expensive. It's something you should all have a copy. So just if you want a copy, just reach out to me and I'll make sure you get one. So thank you so much. Thank you and have a nice evening. Thank you, the
Thank
Israel.
you.
Thank you, Instagram.
Thank you.
Yes,
Thank you.
be sugar. Say how do we get a copy? Just send me a DM. Send us a DM and I will send you a number to get it how to get the book. It's a book it's a book you can also gift couples as they are getting married so that they can, as they're getting married, honeymoon, they start planning. It's good to prepare for that, and I think it's a good thing. So they're very grateful that you give them something like that. I think it's a very good wedding gift as well. All right, good night,
Yes.
everybody. I'll see you
Thank
next time.
you.
All right, good night.
Thank you. Bye
Bye.
bye.
Bye. Bye.